Hello friends, welcome to today's lecture on question banks. We'll do question banks from UWorld. So let's start. This question says that a 50-year-old man comes to the emergency department due to a large painful skin lesions. He does not remember sustaining any trauma. He was recently diagnosed with atrial fibrillation for which warfarin was begun. The patient noticed the skin lesion about 36 hours after starting the medication. Temperature is 36.7 degrees Celsius. BP is 130 upon 80 mmHg and the pulse is 88 per minute and irregularly irregular. Physical findings are shown in the image below. The remainder of the skin examination is normal. Which of the following is the most likely cause of this patient's skin lesion? Pause the video and think of the answer. Now, as this patient was started on warfarin to prevent thromboembolism secondary to atrial fibrillation, the sharply demarcated purpuric lesions likely represent warfarin-induced skin necrosis. So these are sharply demarcated purpuric skin lesions. This is a rare complication that can occur in individuals with underlying protein C or protein S deficiency shortly after starting warfarin. This protein C and S are innate anticoagulants that are vitamin K dependent, as are coagulation factors 2, 7, 9 and 10. Warfarin inhibits epoxide reductase, which is responsible for regenerating or activating vitamin K. Thereby, it leads to decreased levels of these proteins. Factor 7 and protein C are depleted first due to their shorter half-life. The early loss of protein C leads to a transient hypercoagulable state that persists until the other coagulant factors are sufficiently inhibited. In patients with protein C or S deficiency, this prothrombic state is exaggerated, promoting microvasculature occlusion and hemorrhagic skin necrosis. Treatment of warfarin-induced skin necrosis includes discontinuing warfarin and administering fresh frozen plasma or protein C concentrate. So the answer to this question is D, that is the protein C deficiency. The other options are inappropriate as the allergic drug reactions are immune-mediated hypersensitivity reactions that can have variable cutaneous findings ranging from diffuse erythematous eruptions to extensive blistering and exfoliation. Example as seen in cases of Stevens-Johnson syndrome or toxic epidermal necrolysis. However, this patient's recent warfarin use and localized skin findings are more suggestive of warfarin-induced skin necrosis. So, therefore, the choice A is not the appropriate answer. Whereas in choice B, the antithrombin deficiency can be inherited, that is autosomal dominant, or can be acquired, for example in cases of cirrhosis or nephrotic syndrome, and presents with venous thromboembolism. Example deep venous thrombosis or pulmonary embolism, and they are resistant to heparin. So this all demonstrate that this is also not the appropriate answer. Whereas the heparin-induced thrombocytopenia is an autoimmune phenomenon that causes atrial and venous thrombosis. It can produce skin findings similar to this patient's but would generally be associated with thrombocytopenia and recent heparin use. As there is no indication of heparin use, the answer C is also not appropriate. Vitamin K deficiency is usually associated with easy bruising and bleeding, although thrombosis could potentially occur in patients with concomitant protein C deficiency. However, vitamin K deficiency most often occurs in patients who have fat malabsorption or those who are taking broad spectrum antibodies. Since this both are not the case in this patient, therefore vitamin K deficiency is also not appropriate. The most appropriate is protein C deficiency. A 1-year-old African American boy is brought to the emergency department by his parents with a 3-hour history of severe swelling and tenderness of the hands and feet. They do not know what caused the swelling and say that the boy cries when his hands or feet are touched. The patient has no history of recent illness and is up to date on all immunizations. The boy attends daycare, but his parents are unsure about any sick contacts. His family history is significant for an older brother who died of pneumococcal sepsis at age 6. Physical examination shows bilateral severe swelling of the hands and feet. Which of the following is most likely abnormal in this patient? Pause the video and think of the answer. In this patient, African American, young old, with severe swelling and tenderness of the hands and feet are suggestive of dactylitis, which is one of the complications that is caused by the sickle cell anemia. Dactylitis is a swelling of the hands and feet that is a common presentation of sickle cell disease in young children, and the sickle cell disease is the most common autosomal recessive disorder in African Americans. Also, the patient history or the patient's family history, which is significant for an older brother who died of pneumococcal sepsis, also suggests of sickle cell disease because patients with sickle cell disease are predisposed to infections with encapsulated organisms, example Streptococcus pneumoniae, because of repeated splenic infarcts which causes functional asplenia. In this slide, we can see the blood smear of a patient suffering from sickle cell anemia, where we can see the red blood cells to be sickle shaped. The sickle cell disease basically include the 3 common manifestations. The first is the hemolysis. Hemolysis is due to repeated sickling of RBCs leading to permanent deformation and premature erythrocyte destruction by macrophages and mechanical stress. Therefore, the hemolysis is both intra and extravascular. Intra where it takes place inside the vessels and extravascular where it takes place outside the blood vessels, basically in the spleen or in lymph nodes. The hemolysis results in increased indirect bilirubin and lactate dehydrogenase, whereas it leads to decreased haptoglobin. Haptoglobin binds circulating hemoglobin and reduces renal excretion of free hemoglobin, preventing tubular injury. Second manifestation that we see is vaso-occlusive symptoms. Patients with sickle cell disease may experience pain from hypoxic tissue injury and infarctions due to obstruction of small vessels by sickled cells. Microvascular occlusion typically involves the bone marrow, periosteum, and deep muscles but can occur in other organs as well. This patient is presenting with dactylitis, that is the hand-foot syndrome, which results from small infarctions in the bones of the extremities. These infarctions cause swelling, tenderness, and warmth. Dactylitis is common in patients with sickle cell disease during the first few years of life, as the affected bones still contain hematopoietic bone marrow. In other children and adults, vascular occlusion leads to pain crises like acute chest syndrome, leg ulceration, priapism, autosplenectomy, and stroke. Third manifestation that we see is infections. Patients with SCD or sickle cell disease are predisposed to infections with encapsulated organisms. Examples Streptococcus pneumoniae or Haemophilus influenzae, because repeated splenic infarcts cause functional asplenia. So the answer to this question will be abnormal serum haptoglobin. The rest of the options are incorrect because the choices A and E are incorrect, as the chronic anemia in sickle cell disease can result in cardiomegaly due to chronically increased cardiac output. That is when the systolic function is largely preserved due to an increase in stroke volume. However, this typically does not occur until after infancy. Older patients can develop congestive heart failure due to ischemic cardiomyopathy and present with decreased cardiac output and increased systemic venous pressure. But since this patient is just 1 year old, this too will not be the cause. Now the choices B and F, that is the serum albumin and urine cortisol excretion, are typically normal in patients with sickle cell disease, so they will not be abnormal in this condition also. Whereas the choice C, that is serum C4 complement fraction, it is actually due to hereditary angioedema, which is a rare autosomal dominant disorder that is associated with painless episodes of swelling involving the face, lips, larynx, and extremities. It is actually caused by C1 inhibitor deficiency and not due to vasoocclusion, and therefore this is also not the appropriate answer to this question. In the next question, a 50-year-old woman comes to the physician due to periodic reddening of her skin that is starting to become bothersome. The redness involves mainly her face and neck and is accompanied by mild warmth. The episodes initially lasted only a few minutes, but now they sometimes exceed 20 minutes. The patient has also had persistent watery diarrhea and associated abdominal cramping for last several months. Physical examination shows several purple vascular lesions surrounding her nose. Urinary excretion of 5-hydroxyindole acetic acid over 24 hours is increased. Abnormal imaging shows a tumor in the small intestine. Which of the following is most likely responsible for the patient's condition? Stop the video and think of the answer. Now, this patient presents to us with the features of carcinoid syndrome. For example, the patient presents with flushing, that is indicated by redness involving mainly her face and neck. So there is flushing of the skin. Also the patient has watery diarrhea, which is also one of the features of the carcinoid syndrome. And the urinary excretion of 5-hydroxyindole acetic acid is also one of the diagnoses for the carcinoid syndrome. The carcinoid tumors most frequently arise from the enterochromaffin or the endocrine cells of the intestinal mucosa. These cells produce a number of vasoactive substances such as serotonin, bradykinin, and prostaglandins. When the tumor is confined to the intestine, these secretory products are metabolized by the liver and the patients do not develop carcinoid syndrome. In contrast, if intestinal carcinoid metastasizes to the liver, then these vasoactive substances bypass the liver and enter the systemic circulation, resulting in carcinoid syndrome. Thus, the answer to this question will be metastatic carcinoid and not the localized carcinoid. Though there are some extraintestinal carcinoid tumors, example bronchial carcinoid, which can cause carcinoid syndrome without metastasizing, as the vasoactive substances are secreted directly into the systemic circulation, bypassing the hepatic metabolism. Now this slide represents to you some of the features of the carcinoid syndrome. The clinical manifestations of the skin include flushing, telangiectasis and cyanosis. The GIT findings include watery diarrhea, cramping. The pulmonary finding says about the bronchospasm, dyspnea, wheezing. Cardiac finding includes valvular fibrous plaques, mostly in the right than the left, and the diagnosis is based on elevated 24-hour urinary excretion of 5-hydroxy-indole acetic acid, and the CT and MRI of abdomen and pelvis is taken to localize the tumor, whereas the treatment is octreotide for symptomatic patients and the surgery for liver metastasis. Octreotide is a long-acting analog of somatostatin, and its mechanism of action for carcinoid crisis is via its known inhibition of vasomotor product release from the tumor and blocking receptors of these substances, thus aiding in the clinical manifestations and in the features of the carcinoid syndrome. In this case, a 30-year-old woman comes to the emergency department with sudden onset abdominal pain and ascites. Laboratory studies shows anemia, reticulocytosis, leukopenia, and thrombocytopenia. Flow cytometry of the patient's peripheral blood cells using the appropriate monoclonal antibodies show CD55 and CD59 deficiency. CT scan of the abdomen shows hepatic vein thrombosis. Which of the following is the most likely cause of the patient's anemia? Pause the video and think of the answer. This patient's combination of hemolytic anemia and hypercoagulability, as suggested by hepatic vein thrombosis, and pancytopenia, as suggested by the laboratory studies, which shows anemia, leukopenia, and thrombocytopenia. These all are characteristic of paroxysmal nocturnal hemoglobinuria. Despite the name, hemolysis has been shown to occur at low baseline levels throughout the day, with exacerbations caused by a variety of inflammatory triggers, example, infections and surgery. PNH or paroxysmal nocturnal hemoglobinuria is caused by acquired mutation of the PIGA gene. PIGA gene, that is PIGA. PIGA gene with a clonal population of multipotent hematopoietic stem cells. This PIGA or PIGA gene is present within a clonal population of multipotent hematopoietic stem cells. This gene is involved in the synthesis of the GIP anchor. GIP, that stands for glycosyl phosphatidyl inositol anchor, a glycolipid that is necessary for the attachment of several cell surface proteins, including CD55, that is decay accelerating factor, and CD59, that is MAC inhibitory protein. These proteins help inactivate complement and prevent the membrane attack complex from forming on normal cells. Absence of this GPI anchor results in CD55 and CD59 deficiency and complement mediated hemolysis. The hemolysis occurs more often at night because complement activity is increased during sleep due to lower blood pH. Patient also develop thrombotic complications, example, Budd-Chiari syndrome, likely due to release of free hemoglobin and other prothrombotic factors from lysed RBCs and platelets. PNH is often associated with pancytopenia and aplastic anemia. This is possibly due to autoimmune attack against GPI antigens on stem cells. Flow cytometry is the gold standard for the diagnosis of PNH and will show absence of the GPI anchor and CD55 and CD59 deficiency. Thus, the most likely cause of the patient's anemia is complement activation. Other options are inappropriate, as factor V mutation can result in an abbreviation called factor V Leiden, which is resistant to cleavage by activated protein C. Patients with factor V Leiden are are at increased risk of thrombotic events, but hemolytic anemia and pancytopenia are not seen. And thus the factor B is not the appropriate answer to this question. And whereas in the option C, intracellular dehydration occurs during the pathogenesis of sickle cell anemia and spherocytosis. So it is also not the appropriate answer. And mutations affecting the beta globin chain is due to beta thalassemia. So it is also not the appropriate answer. And last, the splenic sequestration is a common complication again for the sickle cell anemia. So it is also not the answer. The answer is due to complement activation. Now this slide demonstrates the mechanism of paroxysmal nocturnal hemoglobinuria. Here there we can see that the GPI or glycosyl phosphatidyl inositol protein anchors the CD55 and CD59. The CD55 is decaying accelerating factor and CD59 is MAC inhibitory protein. They both actually inhibit complement deposition. If there is no CD55 and CD59, then there will be membrane attack complexes formed in the normal RBCs, which will lead to lysis and the release of free hemoglobin. And this membrane attack complexes is actually formed by the complement activation. Now, a 32-year-old woman reports fatigue and malaise over the last several days. The patient has had not any sick contacts. She does not appear to be in acute distress. After her initial evaluation, thrombocytopenic purpura is suspected. Which of the following findings is essential in making the diagnosis? Pause the video and think of the answer. Thrombotic thrombocytopenic purpura TTP is one of the primary thrombotic microangiopathies which are characterized histopathologically by thrombi in arteriolar and capillary microvasculature. Hallmarks of the diagnosis are microangiopathic hemolytic anemia, which is a non-immune hemolytic anemia with schistocytes, and thrombocytopenia without any other obvious cause. TTP was initially described as a pentad or the 5 triads of fever, neurologic symptoms, kidney disease, microangiopathic hemolytic anemia and thrombocytopenia. But however, up to only 1/3 of patients do not have neurologic abnormalities, half have normal kidney function and only 1/5 have fever, and thus the currently only microangiopathic hemolytic anemia and thrombocytopenia are required to consider the diagnosis, which significantly reduced in ADAM-TS13 activity and helps in confirmation of TTP. So the answer to this question is E. Hemolytic anemia. Plasma exchange is life-saving and should be considered in patients who have microangiopathic hemolytic anemia and thrombocytopenia, and then one who is suspected for thrombocytopenic purpura, that is TTP. Now this slide presents to you the summary for thrombotic thrombocytopenic purpura TTP. The pathophysiology behind this situation is decrease in the ADAM-TS13 level. This actually results in uncleaved von Willebrand factor. Von Willebrand factors are usually found in multiples, and to destroy them or to cleave them into monomers, there is need for the ADAM-TS13. If there will be no ADAM-TS13, then the platelets will tap against each other and will lead to thrombosis. So there will be platelet aggregation leading to thrombosis. They can be acquired like due to autoantibody or they can be hereditary. The clinical features here is hemolytic anemia that results in increased lactate dehydrogenase and decreased haptoglobin with schistocytes, and thrombocytopenia that results in increased bleeding time with a normal PT and PTT. normal PT and PTT because there is no effect on the coagulation factors, and thrombocytopenia because the platelet aggregation leads to use of the platelets and therefore decrease in the count of floating platelet. And schistocytes is actually also known as the helmet cells that is formed because of the mechanical damage to the RBCs due to the thrombosis found in the microangio vessels, that is the small blood vessels. Now, these two are the most important clinical feature, but it can sometimes be associated with renal failure or neurologic manifestations and fever. And the management is plasma exchange, glucocorticoids, and rituximab. This is all for today. Thanks for watching. If you like this video, please do subscribe and share.